Good morning or good afternoon to you all. My name is Professor Brett Williams. I'm the current head of department, the Department of Paramedicine at Monash University in Melbourne, Australia, and I'm really privileged and honoured to be presenting, I think, at the very first Libyan Emergency Medicine Conference later in this week. Today, I would talk for the next 20-25 minutes on providing with an overview of paramedicine, both from an educational and clinical practice perspective in Australia, and hope to shed some new light to delegates on how the systems of care and tertiary education and research takes place within paramedicine and paramedics as clinicians. Again, thank you very much for the opportunity to present. It's the first time that I presented to a Libyan delegation before. Thank you to Dr. Ibrahim for the opportunity. Thank you to the organising committee, and also thank you to Dr. Ahmed for making sure that the presentation is presented today on time. So thank you. So I'll talk about the following, a little bit about Monash University, and then drill down a bit deeper in terms of what we do as a Department of Paramedicine. I'll provide an overview of paramedicine in Australia, and then some history, different paramedic roles, and then a brief overview of generally how Australian ambulance services operate. I should also just quickly highlight that my background is a registered paramedic and have moved into the university sector and have been at Monash University since 2004. So Monash University, if you've not heard of the university, is located, as you can see, in the southeast corner of Australia, and we have 4 main campuses. We have a really large global footprint, campuses in Kuala Lumpur, Malaysia, a new campus in Jakarta, Indonesia, and research and training facilities in China, India, Italy, and the United Kingdom, with well over partner universities and training facilities. In terms of people, so we have well over 80,000 students from more than 170 countries. About 40% of the overall student enrolments are either international students studying abroad or international students studying in Melbourne, Victoria. Well over 16,000 staff, good teaching to student ratios, and around 350,000 alumni across the globe. So renowned as one of the most international university in Australia. Importantly, for those of us who work in the university sector, the most recent Times Higher Educational rankings were presented about 2 weeks ago, and Monash has risen to a fairly lofty number 44 in the world, and also 57 in the world with the QS World Rankings. So obviously very impressive, probably made more impressive with the university that's only 60 years old, so really young university. And as a Department of Paramedicine, we're really honoured and privileged that a research-intensive university such as Monash has embraced the profession of paramedicine and has done for well over 20 years. And again, we're very honoured and thrilled with that, and that provides certainly the opportunity for paramedics like myself and others in Australia, and our international students and colleagues and partners, the opportunity to develop as a profession and build our own unique knowledge and scholarship. So in terms of the Department of Paramedicine, as I've highlighted, we've been associated at the university since 1999, and we have 2 campuses where our undergraduate program is run, and also our second campus where we run our postgraduate critical care students. As you'd expect, multitude of different facilities, purpose-built facilities for paramedics. As you can see, garages, multi-floor for students, and extrication trauma facilities, and as you can see, lots of different simulation modalities, certainly with a large cohort of students, limited clinical placements, certainly in hospitals and their ambulance services, that we need to ensure that modalities across the clinical spectrum are provided to students. In terms of the department, I guess globally we would be considered very large. So we have just short of 20 academic staff. One of our strong commitments is the professionalisation of paramedicine, both domestically in Australia, but probably more importantly internationally. And we have what we call adjuncts or honorary staff, and you can see we almost have as many adjunct staff as we do full-time academic faculty, and a range of different countries: Jordan, Ireland, UAE, Saudi Arabia, United States, Scotland, and Canada, as well as a number of staff from Australia. So that again reinforces and supports our commitment to the internationalisation of education and scholarship and research. Of course, like any clinical department, we would not survive without our sessional or tutor staff. We have about 85. The next few dot points where you can see bold that are the number of students that have actually graduated in the respective programs. So we have a 3-year bachelor program with a cohort currently across the 3 years of about 380 students. We have 9 students in the honours program, which is a year-long program that sits above the 3-year program. That's purely a research training program that is a direct pathway to PhD and bypasses any need to do any master's coursework or research. And we have well over 100 students in our master's coursework and or research program. And probably the most significant from a maturity of our profession is the second last dot point, where we've recently graduated our 32nd paramedic PhD, and we currently have 26 currently enrolled. And obviously many countries you can see, and multiple candidates who have now graduated, gone back to country: Jordan, Saudi Arabia, the US, Canada, Ireland, many from Australia, as you'd expect, New Zealand and Scotland. So that gives you a bit of an idea of the department and how we work to roll out the programs in Melbourne, Australia. I should point out many of these programs are delivered online, with students never actually needing to come to Melbourne. Here's just a bit of a brief graph just to show, I guess, the rate of publications per year and the trend obviously going upwards, and that reflects again not just what the faculty is doing inside the department, but moreover is demonstrating a real commitment to research scholarship, particularly through the honours program, the master's program, and then the PhD, where of course the candidates are expected to publish a lot. And certainly, as you'd expect, the faculty members, if we don't publish, as the saying goes, we perish. So that's a really pleasing trend, and is a significant number of publications, certainly from a department of paramedicine. In terms of the courses that we offer, we run courses that run for a day, particularly ECGs, for example, 2-day advanced airway courses, and we're currently running our very first research short course, which runs over 8 weeks. And again, that's fully online, and we're up to week 5 with about 32 candidates all around the world. We offer a 3-year bachelor program. As I mentioned, the honours program is a 1-year program that sits on top of that. We also offer a graduate diploma in health science research, which is largely purely about, again, more research. Then one of our masters is really focused on clinical paramedicine, and that's the Master of Specialist Paramedic Practice. We have 3 specialties within that program, and that's the 1.5 or a 2-year full-time program, or 3.5-year part-time, and that's again delivered online, or can be delivered in Melbourne on campus, but the vast majority of candidates are doing that online. It involves intensive care, aeromedicine and aeromedical retrieval, and more recently community care, or community paramedicine as it's known in different parts of the world. So another Master of Advanced Healthcare Practice with a major in paramedicine, and that is a pure research master's, as is the Masters in Philosophy. and often the masters in philosophy migrate straight into a PhD, and there's the last one is a PhD program in paramedicine. So these programs have been around for us since about 2006 in the graduate space, and 2004 when we first offered the Bachelor of Paramedicine. So tertiary education within paramedicine in Australia is certainly not, Monash is not a new thing, and it's something, again, we've been very fortunate, and I'll touch on that in a moment, very fortunate that we have the opportunity to teach, learn and develop at a university level. That certainly when I started in the ambulance service in 1992, that was never a possibility, and we did our training locally at a community college. So paramedicine broadly in Australia is, as you know, may or may know, Australia is a very large continent, not a particularly large country in terms of population, so around 24 million, and the majority of the population lives around the eastern seaboard, and through the vast majority of Australia is desert, and takes about, from this point to about here is a 6-hour flight. It's important to note that each state or territory has one jurisdictional emergency ambulance service, and each ambulance service has one medical director. Each state or territory may also have a number of non-emergency ambulance providers to provide support for the non-urgent transportation of patients. We were most recently nationally registered, so we're now fully registered as a legitimate healthcare profession, and join the likes of obviously medicine, nursing, psychology, physiotherapy, and the list goes on. And around 22,000 registered paramedics in Australia. And I think an important note, particularly for international delegates, is the parity between male and females. And the majority of our students at university, about 65% of all of our students are female to male. As you can see, it's a young person's profession, very difficult with the workload and shift work, as you probably all expect. So some nuances around what's perhaps different in Australian paramedicine perhaps to other countries. Just different, not better, not worse, just how things have evolved in Australia. And that's taken us, and I'll show you a slide shortly that talks about the time that has taken from us really being legitimate ambulance drivers, where there was more focus on maintaining an ambulance, its mechanical features, than actually caring for the patient in the back, to now having highly trained, independent, legitimate healthcare professionals. And that's taken us 50, 60 years. And that time scale is not really negotiable. We don't have national exams at all, so graduates finish the program and finish all of our healthcare programs, and those programs are accredited, and that standardization has been approved through the national accreditation scheme. As I mentioned, the parity is very, very close between male and female. A really significant factor, and that's a part of the move of paramedics and paramedic education in the universities, led to professional rates of pay. And as the head of an academic unit, one of the biggest constraints we have is actually bringing in clinicians to the academy, because the university can't match the salaries. So the state that I'm in is Victoria, which is really low down, as I pointed in the earlier slide of the map. In the bottom southeast corner, the paramedics earn particularly high salaries, much higher than most allied health, and certainly some of the early ranging in registrars as well. Part of the national registration scheme, as I said, and that occurred in 2018, and that was a significant milestone for those of us who have been around in the profession for a long time, that we finally had received the national recognition from our healthcare peers, and recognised that what paramedics do and the medication, the interventions they provide, are potentially very dangerous, and that serves as an important point of maintaining community safety standards. Compared to other jurisdictions, other countries, we're not linked to to a fire service. So the ambulance service provision in Australia is run and delivered by an ambulance service, not a fire system, completely separate. The ambulance deal with health emergencies, and the fire brigade deal with fires and other activities such as that. And the last one here is certainly in all states and territories here, we have one medical director, but their role is more administration and governance. Paramedics here are completely independent, work autonomously using clinical practice guidelines, not a stepwise linear set of protocols. And if the paramedic crew need to intubate, provide medications, or a combination of any of those things, they do that independently without receiving a call to the physician at the hospital. And that's been the case here for many decades. There are some variations between each state and territory, and again, that's where I currently are now, and where Monash resides. There are some variations, again, between each state and territory, but largely you can see here that where I am now, a very well-established program is that depending on the call might be abdominal pain, one ambulance with a lower level crew and qualifications may attend. If it's a suspected cardiac arrest, for example, or major trauma, then two ambulances will be responded. One crew will be a lower qualification advanced life support, and there will be another crew that will be intensive care or critical care trained, and both crews will respond accordingly. And then depending on the severity or the condition of the patient, the high qualified crew will take the patient to the hospital, or the lower crew will take them to the hospital. We have again, particularly in this state that we're in, we have 5 helicopters, many rotary wing that work pretty much 24 hours through the day, and they do that through insurance and ambulance subscriptions largely. Depending on which state or territory you're from, there are motorbikes, there are bicycles, there are these community or extended care paramedics going out to the community, often not in an ambulance, in a sedan, and their main function is to provide some basic primary health care to stop the huge issue we have in this country, no doubt in most parts of the world, and that is the significant burden on being placed on hospitals and what we call ramping, where there's dozens of ambulances stuck at the ED, not able to offload their patients. And as I mentioned, the vast majority of Australia is desert. From this point to this point would take probably a 5-hour drive, and you can imagine that there's a whole range of space here, and we would not survive. Every ambulance service in the country would not survive without what's called community officers or volunteers, and be able to, might be a local butcher or a local news agent who will respond with the local ambulance paramedic. And we also have some fire first responders in some of those areas as well, again, to provide support where there's no formal ambulance station. Those who have been to Australia and have seen the vastness will understand what I mean by that. That it's a major challenge for every ambulance service. So how did this all come about? Why am I talking to you today as a registered paramedic who's been at university for almost 23 years, and largely that came about by 3 things, and that was really driven by Victoria, where we're at, and other states and territories soon followed. And that was initially through the state government, who had decided that it was perhaps time for the paramedics to move into a different funding model, and that rather than the ambulance services being funded to employ paramedics, maybe it was time that the programs went to the universities. I'll move to the last one, and that's paramedics. The paramedics were very parochial and felt it was time that they came out of that semi-professional status and moved into the university sector. probably like 30 years or so behind nursing, not at all dissimilar to that. And probably the middle section has pulled all of that together. And in my view, undoubtedly, the only reason, again, that I'm talking here today is of the medical profession support and endorsement and advocacy that we should move into the tertiary sector. And here's just a range of medical physicians, intensivists, emergency physicians, general practitioners, and the list goes on and on, who've all been integral to the movement of taking us from literally ambulance drivers, semi-profession, to being now, as I've repeated a few times, legitimate independent healthcare professionals who have PhDs, who are undertaking independent research, and would acknowledge every single one here on these slides and others that have contributed to that. And I do a lot of presentations around the world, and this is a key factor, is medical endorsement and advocacy is critical. Here's a bit of a time frame of where we've moved, and as you can see, really from obviously the first aid that occurred before 1970s, that was very, very, very basic. Really from the 1970s, the first it was an ambulance officer training centre, low level, some hospital-based training. Then through the 80s, we moved to a diploma, which was 3 years done on campus in classrooms, and then on site as almost like an apprentice. Then through the 90s, that's, as you can see, the first conversion of previous diploma holders with an opportunity to convert upskill into the bachelor's was 1994, and the very, very first pre-employment degree occurred in 1999. Monash was 2004, and many, many others around the country occurred 4 or 5, 6 years after that. As you can see, that's the programs are not new, and it's very well established, and has been for many, many decades. Then in the 2000s, we had the graduate diploma, masters and PhD, and the very first masters and PhD programs were, fortunately for what we do here, were developed at Monash in 2006. In the 2010s, we've started to see an emergence of additional graduate certificates. So like a third of a master's, where we're looking at extended care, disaster medicine, for example, aeromedicine, and currently there's a range of other new programs, particularly the masters in community paramedicine, given the importance of that for healthcare. And also there's a new tactical medicine program, which is receiving a lot of attention. So to be a paramedic in Australia, an entry practice program has to be either a 3-year bachelor or a 4-year double degree, and there's about 2 or 3 programs in the country that have a nursing and a paramedic 4-year degree, and there's one program that is a conversion for registered nurses who want to become a paramedic, and that's a 12-month graduate diploma. 17 universities offering 19 programs. It's a very popular profession, paid very well, good entitlements, lots of annual leave, etc. Really exciting job, the independence, so on and so forth. Currently across the country, there are about 8,500 paramedic students across the country, and a real imbalance of supply and demand, and that's led to recognition of the standards set by the universities in Australia and other countries who are also suffering major shortages, which we don't tend to have an issue here. We have an oversupply of paramedics. So we've had a direct pipeline for some time here to UK, particularly London Ambulance Service. I believe that probably about half of the workforce, I might have this wrong, but I've heard that about half of the workforce in London Ambulance Service are Australian graduates, and there's pipelines also to New Zealand, and more recently to the US. There are 7 universities that offer graduate programs, as you can see: intensive care, aeromedicine, community care, disaster, tactical, research and then PhDs. The type of roles that we have in the country range from, as mentioned, volunteers or patient transport officers, again done at a local vocational setting. The advanced life support might be considered or comparable to an EMTI, intermediate, and again that's a 3-year entry to practice, bachelor or a double degree, and then includes a 1-year internship with a clinical instructor in field and then signed off. If you then wanted to move to the next high level, that's intensive care. That's a 1.5-year graduate diploma or a 2/3 of a master's program, and that then also includes another 1-year internship. Next is the extended care, which is another 12 months that includes either grad cert or graduate diploma, and they can either come from the ALS paramedic group or also the intensive care paramedic group. And then lastly, we also have the flight paramedic, which is again another 1-year graduate certificate plus another 1-year internship. So what does that mean? And what's perhaps different to other countries is the length of time that the country and the system, the expectations are to be considered experienced, and that is a big difference between other countries where many other drugs and interventions would be provided, but they might be done after 6 months or 1 year or 2 years. That would never happen in Australia. It's just very different, not better, just how the system's been set, and that's the way it's been for many years. This is a broad picture in terms of generally we use 000, which is our emergency ambulance number. This depicts the majority of what most ambulance services in Australia would use. You have your primary triage where a call's received. Call takers follow a standardised AMPEDS dispatch grid and will ask questions, and that may receive an emergency ambulance and be directly taken to an emergency department. Of course, the demand management is such that for some time we have a very well-established referral service where the primary triage will receive the call, may determine that it's not a primary triage issue, that an emergency ambulance is not required, would send that to a secondary triage person. They would then continue to ask more questions, probe more deeper. That may include or an upgrade to an emergency ambulance response, which may go to an ED, or as it says down here, the right care, right place, right time. There's an attempt to minimise that every patient, that every ambulance person went to hospital. A non-emergency transport, which could be to any type of healthcare service, such as the GP clinic, or indeed that no transport was required at all, no ambulance would turn up, and that a locum doctor or a nurse on call might give some advice. And that's been largely very successful with very small issues in terms of any major negative patient outcome. Now, these are some of the key people issues that the ambulance service in Australia face, and that's workplace behaviours, occupational violence, where violence against paramedics is occurring, manual handling injuries, psychological injuries, mental health burnout, and flexibility with work arrangements. What I can say, and we've just finished an international research priorities study, and that hopefully will be published early in the new year. And that includes participants all around the world, all participants from the 6 regions in the world. And I can tell you that probably the number one issue for paramedics or people working in ambulances or the out of hospital sector is sleep fatigue, burnout, mental health, good governance, and happy to share the preliminary results with anyone that may like that, and certainly give you some links to the paper when it's published. I guess the point I would like to make is that the ambulance service here might seem different in Melbourne to what it might be in Libya, in terms of what it might be in Morocco, what it might be in Minnesota, what it might be in Johannesburg. But I can tell you, in reality, the ambulances and the uniforms may be different, but the core people issues, the core clinical issues between those countries are actually not different. And hence why we wanted to do this international research priorities study to identify that every country largely is facing big issues around paramedic health and welfare and wellbeing. Again, some of these vary between different jurisdictional ambulance services in Australia, but the main KPIs are cardiac arrest outcomes. And if you're interested, you could have a look at Ambulance Victoria VACAR data and some of their publications in terms of what they've been able to achieve. Pain scores, clinical performance, dispatch and response times. Obviously, that's a big thing. Paramedics are kind of earmarked for no longer than 20 minutes on the scene. Major trauma, whether the patients are being sent to the right hospital. So we're taught to drive past certain hospitals or call the helicopter. So they must go to certain designated trauma centres, and lastly, customer satisfaction with follow-ups. In terms of governance, as I mentioned, the protocols stepwise don't exist anymore. They certainly did when I started in the early 90s, but now we use these things, which are clinical practice guidelines, and allows the paramedic to flip between any of these. And you can see there's no numbers, and gives all sorts of different options to practice. How that's done is use the internationally agreed, recognised agreed to system, usually on a 3-year cycle. Sometimes we find the guidelines have been updated a little bit quicker, which is not necessarily received well by the paramedic, because they're constantly being updated and having to recall certain drug dosages, for example. And it's overseen by the Clinical Practice Development Committee, which involves a multidisciplinary committee, both medical experts across the spectrum of medicine, as well as paramedics themselves. And that's an important part of the maturation or maturity of paramedics who have now all on these committees, have done PhDs, are very well versed in systematic reviews, meta-analyses, running quite complicated studies, being able to appraise and synthesize the articles. And that's been an important part of our development as a profession. And those are approved by the Medical Advisory Committee. And this part in particular is a key part of the medical directors. And recall that of the 8 states and territories in Australia, each state only has one medical director, and this is a key part of their role. And they would provide the oversight to make sure that the latest evidence-based practice principles and evidence are being applied to those guidelines. The ambulance service here for some time. The ambulance paramedics have a tablet that's evidence-based. No writing on paper. That's all linked straight to the hospitals. And again, in Victoria, that registry is linked to other registries such as cardiac arrest, trauma, stroke. So when it comes to doing research, and as you can see, really strong history of and culture of continuous improvement, as well as strong research capability, means that we can say what were the outcomes, not just from the paramedics and what they did on the scene, but then follow that with the registries, whether it's cardiac arrest, trauma, or stroke, and then identify patients' outcome at 30 days that are all matched. That's really significant in terms of developing the research. Here's just an example of some of the guidelines that are used. The book is quite thick. Importantly, in terms of patient safety, the paramedics are not expected to rote learn things now. They're actually, we train our paramedics to, if they need to pull the phone out, and these guidelines, Ambulance Victoria CPGs, which I'm using now, referring to, are all freely accessible as an app and on Google as well. And they're encouraged regularly that if they're unsure, is the dose fentanyl 200 mics intranasally or is it 150? Check your guideline live with the patient, exactly what would occur in an ED. And that's taken many, many decades to get out of, because historically that's what we were taught to do, to rote learn, not to actually refer to the guidelines. But as you can see here, these are different color coded. So the blue is for more the higher qualified paramedics, and the green is for everyone. Here's examples of medications, and again, highlighting what they're indicated for, what the contraindications are, and certain medications can be used by all the paramedics or those who are higher qualified. So that is a quick summary. It should be around 20-25 minutes of paramedicine in Australia, both from an education, tertiary education system, as well as clinical practice. I've sent you a link there. Please, if you have any direct questions about the presentation, any of the research we're doing, any opportunities you'd love to collaborate. We're really passionate and committed to international collaborations. And again, please let me reinforce the issues being faced in Libya in the ambulance or out of hospital sector in many ways will be not dissimilar at all to Melbourne and other parts of the world. So please reach out if you have any interest in doing some research collaboration. I'm very happy to share any of the publications we do. And again, that link below will take you to our website, and you can see a range of the courses that I've outlined in more detail. You can have a look at the staffing, their backgrounds, interests. You can look at our local, domestic, and our international partners and who we work with. Again, thank you very much for the opportunity to present to Dr. Ibrahim, the convening committee. A real pleasure. I'm very happy to see you live to answer any questions that you may have. Thank you very much.